sir. We are live, sir. Over to you.
Okay. So thank you very much and very good evening to all the faculty members and the participants. Myself, Dr. Rahul, I am a senior medical advisor working for Panacea Biotech. And I will just take a brief introduction regarding Panacea Biotech. We are actually into two businesses. One is vaccine and the pharmaceutical, the second one. And where in vaccines, we are the fourth largest company in India currently. And we are also the first manufacturer of Sputnik V in India. Along with this Sputnik V, we are having hexavalent vaccines, and we are also working on the different vaccines on dengue and the pneumococcal. We are having 4 R&D centers across India. And along with that, the oncology, which is actually the core specialty or ours, we are having the first generic version of Abraxane with the brand name of Pacliol. With Pacliol, we have done numerous in vivo, in vitro studies, along with one human study also against the Abraxane, and which actually shown the bioequivalence of Pacliol against the Abraxane. So, as a brief intro about Panacea Biotech, and we are very thankful to the Mumbai Hematological Group for providing this excellent academic opportunity to us. So I will not take much time here, and directly I am handling this meeting to Dr. M.B. Agarwal sir for further proceedings. Over to Dr. Agarwal.
Thank you, Dr. Rahul. I'll just share my screen. So, good evening, friends and colleagues. Today, we have Dr. K. Naresh from Hutch as our speaker. He's going to lecture on lymphomas associated with infectious agents. This webinar is brought to you by Mumbai Hematology Group, supported by Panacea Biotech and managed by Mice Ideas. I thank Mr. Shailendra Kumar Srivastava, Dr. Rahul Pathak and team from Panacea Biotech for supporting us, Rajesh Kalpesh and team Mice Ideas for managing our webinars, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Dr. Rekha Nair, Director, Regional Cancer Center at Thiruvananthapuram, our guest speaker, Dr. K. Naresh from Hutch. All our discussants were themselves eminent hematopathologists, and you participants for sparing your Saturday evening from almost 15 countries. We have the delegates who have registered and logged in. Just to tell you about tomorrow morning, 11:30, we have Dr. Marco from Milano. He's going to speak to us on thrombotic thrombocytopenic purpura, 11:30 a.m. To introduce the discussants today, we have eminent personalities from various parts of the country. We have Dr. Tara Roshni Paul from Nijans, Hyderabad. Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital, Jaipur. Colonel Dr. Venkateshan from AFMC, Pune. Dr. Gurmeet Singh from Jawaharlal Nehru Hospital Research Center, Bhilai. Dr. Sandeep Sheth, Hadas Hospital, Ahmedabad. Dr. Jay Mehta from Center of Oncopathology, Mumbai. Dr. Ashim Das from PGI, Chandigarh. Dr. Swati Pai from Manipal Hospital, Bangalore. Dr. Jasmita Das from AIIMS, New Delhi. Dr. Parimal Sarda from Vedanta, Ahmedabad. Dr. Rupam Deka from Bhubaneswar Barua Cancer Institute, Guwahati. Dr. Amrita Saraf from Gangaram Hospital, New Delhi. Dr. Devdeep Dev from TMC, Kolkata. Dr. Tushar Sehgal from AIIMS, New Delhi. Now it's my pleasure to introduce our chief guest of the day, and I'm extremely delighted, honored by her kind acceptance and presence this evening. Professor Dr. Rekha Nair. She is Director, Regional Cancer Center at Thiruvananthapuram. She's Professor of Pathology and Hematopathology. She's trained in hematopathology from NCI US and University of Leeds in UK. She completed her MBBS in 1984, MD in Pathology in 1990 from Government Medical College, Thiruvananthapuram. She has an experience of over 30 years as teacher and researcher. Molecular flow cytometry and FISH labs were started RCC under her supervision. She has received national, international, UK, US, Canada, and Australia patents for discovery of microRNAs in different grades and stages of breast cancers, and filed the patents for discovery of microRNAs in pediatric acute lymphoblastic leukemia. She's a member of the ICMR Task Force for Leukemia Diagnosis. Thank you, and I hand over the platform now to her to inaugurate our webinar and give us some words of wisdom.
Thank you, sir. A very good evening to you all, and good morning to Dr. Naresh and other participants from around the globe. I am indeed honored to be the chief guest today, and thank you, Dr. Agarwal, for choosing me to inaugurate the program. Sir asked me to give a few words of inspiration to the younger generation of hematologists, medical oncologists, and hematopathologists, the budding ones. My foray into administration was totally unplanned. Unlike my becoming a hematopathologist, which was pre-planned and executed with focused attention in each step, I fell in love with the hematopoietic cells, doing an ICMR clinical research program in acute leukemias immediately after my house agency. I chose to do MD path with the sole aim of specializing in hem path. I threw away my permanent faculty position in medical college service to move to RCC in 1995 with the aim of developing myself and the Department of Pathology into a center of excellence in hem path, which I think I achieved. I can unabashedly say that myself, and along with my other colleagues, and in particular, Dr. Sumit Gujral, my long-term friend, we can take the credit for developing hem path as a specialty in India, and with nearly 30 years, more than 30 years of hard work. In my current academic position, I can get things done faster. Currently, we are setting up our own NGS lab this year, which is a little late compared to the national scenario. On a lighter note, I can comment that hem path is always considered as the annoying little sister of histopathology. Actually, I've quoted the words of my colleague, Dr. Priya Jacob, who is currently in charge of the hem path lab in RCC. So frankly speaking, they don't like us because we are like the Iran sibling who hogs all the attention. Of course, we also do it at times because to exist, we need to assert ourselves in hem path. As hematopathologists, you will also learn to assert yourself for good quality reporting, for better equipments, for better reagents, and also for the good of your patient population. So when in doubt, you ask yourself, does this help my patients in any way? If the answer is yes, you know it's worth plodding on. Even if your paperwork looks formidable, the odds insurmountable and the environment hostile. In RCC, I have built up a culture of pathologists interacting with the patients directly on relevant cases and also accessing the full clinical files before a report is issued in relevant cases again. And the resistance of our medical oncology group have almost fizzled out. So my advice to the hematopathology group or the upcoming hematopathologists is keep up the good fight and have your ambition to develop your lab as well as yourself. And for all the budding hematologists, medical oncologists, and hematopathologists, pursue your career with a passion. And we have very good living examples with us, Dr. Agarwal and Dr. Naresh. Whom else to follow? With these words, I conclude, and let me now declare this program, inaugurate this program. Thank you.
Thank you, Professor Rekha Nair, for those very kind words and a very inspiring speech. What can a clinical hematologist do without an excellent hematopathologist? We are as good or as bad as our colleagues from the pathology department are. You go wrong, we go wrong, and the patient succumbs. So the importance of hematopathology in this field can never be underestimated. On this part of the country, Mumbai heads in the treatment of hematology only because we have excellent hematopathologists, so that all the errors done here and there are rectified and then we take over. So hematopathology is unchallengeable part of this part of medical career. Thank you so much for emphasizing this point. I'll again share my screen to introduce our guest speaker now for the day. So friends, Dr. K. Naresh, well-known personality in the field of lymphoma, not only in India, but all over the world. He has been our speaker at multiple occasions, even prior to these webinars being started when we used to meet in person. And then of course, even during these 2 years, he has educated us, entertained us, and has been our friend at multiple occasions. That he has moved from UK to USA. We are bothering him in very early hours of the day. I understand that it's almost just about 5:30 in the morning in the part of US where he is. But thank you so much, Naresh, for obliging us by your kind presence. We move on with his introduction further, which is a formality. He is a hematopathologist with focus on lymphomas, bone marrow pathology, and molecular pathology. He has been in the field for last 30 years. His work trained across 3 continents, North America, Europe, and Asia. Prior to joining Hutch, he was at Hammersmith Hospital. He leads diagnostics, translational research, and training in hematopath. He was the chair of the British Lymphoma Pathology Group. As a part of his activities in BLPG and Royal College of Pathologists, he played a critical role in improving standards of training and practice of hematopath in the UK. He has over 250 publications, and this may be a little old figure, majority of which are in the field of hematopathology. In hematopathology research, his collaborations extend with investigators and institutions in US, Europe, Asia, and Africa. He's a firm believer, and that's a feather in his cap. He's a firm believer in global medicine and science, and in fostering international collaboration to promote translational research and training in hematopathology in other branches of medicine. I invite him to deliver his talk on lymphomas associated with infectious agents. Thank you so much, and over to Naresh.
Thank you, Dr. Agarwal and Dr. Rekha Nair. It's as always, it's a pleasure. It's a pleasure to participate in your meetings. And I also enjoy getting back in touch with my friends in India. I mean, I can see a lot of my friends today. Rekha Agarwal and I go for maybe nearly 30 years, and Rekha, I've known her almost a similar amount of time. Ashim and I interviewed for the same post long ago, and Jay was my resident, so I know a lot of people in this illustrious list of panelists. So let me share my slides. Okay, I just want to make sure I'm the, do I need to swap the, am I okay? Are you seeing the right mode?
Show mode, no.
No, in the slideshow.
Okay, let me swap the, okay, is it better?
Yes.
Yeah.
Okay, let me, now I chose this topic of lymphomas associated with infectious agents because over a period of time, I have developed an interest in this field. It started almost insidiously trying to look at Epstein-Barr virus in Hodgkin lymphoma many years back when I was in India. Subsequent to that, when I moved to, I mean, even before moving to the UK, to the latter part, when I was at Tata Memorial Hospital, I was interested in HIV-associated lymphomas. Then when I moved to UK, I was at a center which was treating a lot of HIV lymphomas. And then we also had a huge number of post-transplant lymphoproliferative disorders. There, actually, my interest expanded. And also, London being a city almost of immigrants, we had other infection-related malignancies and lymphomas. So that continued my interest in, and also many opportunities for research came along in this field, and that has fed my interest and kept it alive. So this was my first work, which really pushed me into this field. This was published in 2000. I mean, the work was done somewhere around 96, 97, and it was finally it was published in 2000, 99, 2000. When we were looking at Hodgkin lymphoma cases, at that time, EBER in situ hybridization probe had just been come into. It was not even in the market. We were preparing the probe ourselves, labeling the probe, and we were testing tumor samples. What we found, we looked at a large volume of Hodgkin lymphoma samples, and we wanted to correlate how EBV positivity or negativity associated with proliferation in Reed-Sternberg cells. So we divided Hodgkins into those where the Reed-Sternberg cell, I mean, where we were not using T67 at the time. We used an antigen called proliferative cell nuclear antigen, and where we divided Hodgkin samples into those where less than 50% of the Hodgkin cells express PCNA, and those where more than 50% of the Hodgkin cells express PCNA. To surprise those which had low proliferation, low PCNA expression, 50% of the Hodgkins were negative for EBV, whereas in those where PCNA was seen in more than 50% cells, an overwhelming majority of cases were EBV positive. That led to the hypothesis that EBV somehow keeps the cells in a proliferative state. And then we wanted to look at the impact of the EBV positivity and the cells being in a proliferative state. And a little bit to our surprise, we found that those which were EBV positive had a better outcome as compared to those which were EBV negative. Subsequent to our work, I think this has been, many publications from India have shown a similar impact. And also one other factor which we saw was 49 of the 50 pediatric Hodgkin lymphomas were EBV positive, and over 50% of the adult Hodgkin lymphoma were also EBV positive. But that most of the pediatric Hodgkin being EBV positive has been again reproduced in later studies from India. The work from the rest of the world has, in the impact on survival, impact of EBV on survival has been different in different parts of the world. But in many of the developed countries where EBV positivity is more often seen in at a later age, the same kind of survival difference has not been found. In fact, EBV positive Hodgkins, which usually occurs in very elderly people, they have behaved worse. And again, all these things have to be seen in the context of the evolving classification. Some of the cases which people might have classified as EBV positive Hodgkin lymphoma in the elderly today might be considered as EBV positive diffuse large B-cell lymphoma. So some of these things which we have seen from the West may need to be reconfirmed. So in today's discussion, I will focus on those lymphoid proliferations which are associated with EBV. And just to, as an introduction to that, infectious agents could either be viruses or bacteria. I'm not going to touch on bacteria-related lymphomas today, which are like Helicobacter, Campylobacter, Borrelia, and Chlamydia are associated with lymphomas. Most of our discussion will focus on Epstein-Barr virus. Partly we will touch on Kaposi sarcoma virus or HHV8, and also a little bit on human T-cell leukemia virus 1, HTLV1, and the HIV. But of course, what we will not touch upon today will be hepatitis C and hepatitis B viruses, which are also associated with lymphomas. Two situations occur in infection-related lymphoproliferative disorders. One where the neoplastic cells are itself infected by the virus. The classic examples for this are these three viruses: the Epstein-Barr virus, the Kaposi sarcoma, herpes virus, and the HTLV1. And there is another situation like hepatitis C, hepatitis B, or the HIV, where the infectious agent is not inside, is not in the neoplastic cells. It is seen, the infected cells are outside of the lymphoma cells. And when we look at the type of lymphoid proliferations, again, we see many lymphoid proliferations of many different types. At one end of the spectrum, we have acute and non-malignant conditions like infectious mononucleosis. At the other end of the spectrum, we have full-blown lymphomas. And in between this, you have chronic non-malignant lesions like the chronic active EBV infection, Castleman's disease, the carrier states of HTLV1, H. pylori gastritis. And also we have polymorphous lymphoproliferative disorders, which some of the entities like the chronic active EBV infection, the borderline between what is reactive, what's neoplastic, can be quite gray and blurry. Another way of looking at infection-related lymphomas associated with infectious agents is to see that there are some lymphomas which are always associated with the infectious agent. They're defined by their association with the infectious agent. There are a set of lymphomas where about a significant proportion are associated with the infectious agent. And there are some lymphomas which are only very rarely associated with the infectious agent. The typical examples of those which are defined by their association with the virus include like EBV positive diffuse large B-cell lymphoma, lymphomatoid granulomatosis, primary effusion lymphoma, so on and so forth, ATLL, EBV positive NK T-cell lymphoma, so on and so forth. Whereas we have a whole lot of other diseases like Burkitt lymphoma, classic Hodgkin lymphoma. And these two are the principal examples: Burkitt lymphoma, classic Hodgkin lymphoma, where only a proportion of them are EBV associated. To the extent one could question whether EBV is really relevant in these two malignancies, or it's just a passenger virus, or it happens to be present, or it doesn't really contribute in any meaningful manner. So there are a whole list of diseases where only a proportion of lymphomas are associated with the virus. Then we can have even diseases like a follicular lymphoma can be rarely associated with the Epstein-Barr virus. And we know that in chronic lymphocytic leukemia and small lymphocytic lymphoma, you can have a Hodgkin-type Richter transformation, which is often EBV associated. And very rare cases of nodular lymphocyte predominant Hodgkin lymphoma also are EBV associated. But in these conditions, it's a rarity. And one may not even test these cases. Like a follicular lymphoma is often not tested for EBV, and nodular LP Hodgkin's may not be tested for EBV. During my discussion today, I will touch on many of these aspects: the epidemiology, to some extent pathogenesis, genomics, immune aspects, and then I'll move on to more of pathology-related topics like morphology and immunophenotyping, diagnosis and differential diagnosis. And at various points, I might touch on patient outcomes and follow up in these diseases. The classic example is of an infection-related lymphoma is the endemic Burkitt lymphoma, and this is a very old slide. When Dennis Burkitt described the Burkitt lymphoma in Africa, what was noted was the peculiar distribution of this disease. This was typically seen in a band across the equator between the Tropic of Cancer and Tropic of Capricorn. And you can see that there are specific countries in South America and in Africa typically is where we see endemic Burkitt lymphoma. And even within Africa, you see that there's a high incidence in Uganda and Nigeria, whereas places like Namibia and Mali, which is outside this belt, show a lower incidence. Of course, one has to remember this work was published in 1988, but subsequent to that, the HIV epidemic has altered the epidemic of the incidence of Burkitt lymphoma. Today, we have a high incidence of Burkitt lymphoma in South Africa, in Zimbabwe, which was not seen before the HIV epidemic. And a similar story, I mean, if you look at multiple countries across the world, as I said, in Africa, nearly 100% of the Burkitt lymphoma is EBV associated, whereas in China, it's only about 25% of Burkitt lymphoma is EBV associated. So there is a variation in the proportion of Burkitt lymphomas which are EBV positive. And a similar thing is also noted in Hodgkin lymphoma, whereas nearly 100% of Hodgkin lymphoma in Africa and South America is EBV positive. Only about 50% of the Hodgkin lymphoma in China or in other parts of the world, or even less than 50%, like in the United States and Europe. The current association would be somewhere around 25 to 30%. So there is a differing association of Epstein-Barr virus with Burkitt lymphoma and Hodgkin lymphoma. And this is data from England, where if one looks at the association of EBV in Hodgkin lymphoma with age, we see some differing patterns. In EBV positive disease, we often see 3 peaks, the first peak occurring very early in the first 2 decades of life, and then you have a second smaller peak around 40 to 50 years, and then a third peak occurring much later. The EBV negative disease is a single peak, which occurs usually between 20 to 30 years of age, and then the incidence falls. So if we plot this in a more general way, we see EBV positive disease having 3 peaks and EBV negative disease having a single peak disease. To a certain extent, I mean, based on these epidemiological factors, people have even questioned whether there are classic Hodgkin lymphoma could actually be 2 different diseases, one EBV positive and one EBV negative classic Hodgkin lymphoma. Similarly, epidemiologists working in Burkitt lymphoma also bring up the question whether Burkitt lymphoma should be classified as EBV positive Burkitt lymphoma and EBV negative Burkitt lymphoma. There are arguments both for and against classifying diseases based on a viral association. Similar to EBV, if you look at the HTLV1, we have a geographic distribution which is uneven. It's predominantly seen in parts of Africa and in South America and in countries like Japan and the Caribbean. But what in today's age of immigration, people should remember that HTLV1 positive diseases could be seen outside of its endemic regions. And also for reasons which we may not completely understand, even places where immigration is less, one could see. So it's important to keep in mind the possibility of HTLV1 infections in areas where it is not acknowledged to be endemic. I'm aware that in southern part of India, like in Kerala, in Vellore, you have HTLV1 positive diseases. And I'm sure we will have some comments from Dr. Nair later. In the UK, which is again has many immigrant population, we see significant numbers of HTLV1 positive lymphomas. Within Burkitt lymphoma, when we look at the pathogenesis, this is a very simplistic model which I'm going to present. What we currently think that is EBV infection of B cells accompanied by other cofactors like malaria and the HIV results in an enhanced B cell activation and proliferation, which results in germinal center expansion. And during the germinal center expansion, most of these cells which may not produce the best fit for the antigen are expected to undergo apoptosis. But accompanying factors like the mid-translocation occurring as an error in the germinal center expansion can actually mean even these cells are expected to undergo apoptosis. But if such a cell is infected with EBV or has other genetic lesions like mutations in the MYC or mutations in P53, so on and so forth, this apoptosis can be abrogated. So a cell which is destined to die can survive. And furthermore, these cells, if they're infected with EBV can provide some proliferative advantage to the cells, eventually resulting in Burkitt lymphoma. Obviously, this is a simplistic view. There are many other questions that come up, which we will try to address. But even within the Burkitt lymphoma, if we compare the endemic or the African Burkitt lymphoma with the non-endemic or European Burkitt lymphoma, there is a molecular heterogeneity. If we look at the breakpoints within the immunoglobulin gene, we see that most of the endemic Burkitt lymphoma have a break in the J region, the joining region of the immunoglobulin gene, whereas the non-endemic non-endemic Burkitt lymphoma, break in the immunoglobulin gene is in the switch region. And when we transpose these molecular differences to where these rearrangements occur, it would appear that the endemic Burkitt lymphoma is likely to, the earliest events of endemic Burkitt lymphoma is likely to happen in the bone marrow, where the joining region recombination occurs, whereas the earliest lesions of non-endemic Burkitt lymphoma is likely to occur in the germinal center in the lymph node, where the switch recombination occurs. So there is molecular heterogeneity in Burkitt lymphoma. And we have tried to address the issue of EBV in pathogenesis Burkitt lymphoma, looking at various aspects. And the work that have been associated with brings three pieces of evidence, which tries to implicate EBV as an important etiological factor, etiological and pathogenetic factor in B-cell lymphomas. One of that is the EBV. So we have seen, and others have shown as well in other diseases, EBV association reduces the need for other driver mutations, other somatic mutations in the host genome. So it can replace mutations in the host genome, thereby suggesting that EBV plays a crucial role. We have also seen that the EBV itself is altered in these malignancies. So the unaltered EBV has a higher ability for lymphomogenesis. And then we have also shown that the type A of EBV is far more oncogenic than type B. So to put it in a more simplistic manner here, like in a normal situation, a B cell gets infected with EBV, it gives a proliferative advantage to this quote unquote normal B cell, which can result in persistent infection of memory B cells. But these are kept in extremely low numbers because they can be controlled by both CD4 and CD8 positive T cells. So though this is a transformed B cell, it is still under the immune surveillance of the T cells. However, if the EBV undergoes a genomic change occurs within the EBV or EBV mutates, this mutated EBV makes this cell unrecognizable by the T cell. So T cell can no longer engage with these cells and these cells can proliferate. Again, this could be quite a simplistic view. And I will try to show you a few pieces of evidence which suggest that EBV is indeed pathogenetically related. This was a work which we did on post-transplant diffuse large B-cell lymphomas. We divided post-transplant diffuse large B-cell lymphomas into those which were EBV positive PTLDs are here, and these are EBV negative diffuse large B-cell lymphomas. EBV positive post-transplant diffuse large B-cell lymphomas had far fewer driver gene mutations as compared to EBV negative post-transplant diffuse large B-cell lymphomas, thereby suggesting that EBV can replace driver gene mutations. We have also seen that this is not only true about in the post-transplant setting. Even when we look at EBV positive diffuse large B-cell lymphoma, they seem to have a lower mutation burden. This is outside the post-transplant setting. as compared to EBV negative diffuse large B-cell lymphoma. Also, as most of the EBV positive diffuse large B-cell lymphoma have an activated B-cell or a non-germinal center phenotype, the crucial difference being EBV positive DLBCLs do not show MYD88 or CD79A mutations, which are very common in the non-EBV negative activated B-cell type diffuse large B-cell lymphomas. Also, EBV positive diffuse large B-cell lymphoma show other alterations in NF-κB, Wnt, and IL-6 JAK-STAT pathways, and they are frequently associated with mutations in CCR6, CCR7, DAP kinase 1, and so on and so forth. So they have a typical mutational pattern. When we look at Burkitt lymphoma, what we see in EBV positive Burkitt lymphoma, there are very few driver gene mutations, much fewer than the EBV negative Burkitt lymphoma. And the alterations in the apoptotic genes is also much fewer. EBV positive Burkitt lymphoma tumors have a higher expression of activation-induced cytidine aminase, and this results in an aberrant somatic hypermutation, and then you have a higher mutational signature. These are these are not the driver mutations. These are the mutations which occur as a result of high expression of the activation-induced cytidine deaminase as a result of somatic hypermutation. So even in Burkitt lymphoma, we see that the EBV positive Burkitt lymphoma, the mutational load in driver mutations is different, much lower as compared to EBV negative Burkitt lymphoma. When we looked at EBV positive post-transplant disease, lymphoproliferative disorders and HIV lymphomas, what we noticed were almost all the PTLDs, where EBV positive PTLDs had type A EBV, whereas in HIV positive lymphoma, EBV positive lymphomas, about half of them had type A and half of them had type B. More importantly, in patients who had type B EBV, they were HIV positive for 105 months before they developed a lymphoma, whereas HIV positive patients with type A EBV related lymphomas developed EBV related lymphoma with a median interval of 7 months. So this suggested that the type B EBV requires a much longer period of EBV positivity to develop into a lymphoma, has a much longer incubation period for lymphoma to occur as a clinical lymphoma as compared to type A EBV. Then we went on to look at what changes in EBV could make EBV more potent as a lymphomogenic event. So this is some experiments which we did in mice. We looked at mice where we introduced EBNA3B knockout. So here are 4 types of mice. One where we just introduced saline, another one where we introduced wild type EBV, and then we introduced for a set of mice EBNA3B knockout EBV. And then for another set of mice, we introduced EBNA3B knockout where the EBNA3B knockout was reverted. So we reintroduced EBNA3B into the EBNA3B knockout virus. So what we saw between these 4 groups were only in those where the EBNA3B was knocked out. That means a mutated EBV was introduced. 50% of these mice developed lymphomas. And then we went on to look at the human, many different types of human tumors, both diffuse large B-cell lymphomas, Hodgkin lymphoma, Burkitt lymphoma from various parts of the world. And we found that in a significant proportion of them, EBNA3B mutations could be found. And these are the images from the mice spleen, which, as you can see here, the wild type mice had very few EBV positive cells, whereas the EBNA3B knockout mice had grossly visible tumors with sheets of EBV positive, large CD20 positive cells. And the EBNA3B revertant, mice infected with EBNA3B revertant had features very similar to the wild type EBV. There were very few EBV positive cells and very few CD20 positive cells. And the EBNA3B knockout mouse, if you look at the CD3 positive T cell, there were very few CD3 positive T cells, as against the mice infected with wild type EBV or the revertant EBV, which had large numbers of T cells. So this led us to hypothesized that in the EBNA3B knockout mouse, there was no immune surveillance by the T cells. And then we went on to show that the EBNA3B knockout transformed B cells produce reduced amount of chemokine CXCL10, and a CXCL10 mRNA was expressed at much lower levels in tumor cell lines from PTLD in PTLD patients bearing EBNA3B mutations. And then we also did migration assays to show that those which had the EBNA3B knockout infected cells were able to attract fewer CD8 positive T cells. And partly this could be reverted by adding supernatant containing CXCL10. So in a way, we built a hypothesis to show how a mutation in the EBNA3B can make the EBV much more potent in driving lymphomagenesis. Then we also looked at how EBV and the HIV can change the microenvironment in lymphomas. We compared the microenvironment of HIV-associated classic Hodgkin lymphoma with HIV-negative classic Hodgkin lymphoma, and there were significant differences. Obviously, there were far fewer CD56 positive NK cells in HIV-positive classic Hodgkin lymphoma. More importantly, what we also saw was there were some unique cells, usually FOXP3 positive cells or CD4 positive regulatory T cells, but we also saw a subset of CD8 and FOXP3 positive cells. This is a double immunostain with CD8 being stained red and FOXP3 in the nucleus stained brown. We could see CD8 positive FOXP3 positive cells in HIV-associated classic Hodgkin lymphoma, which was not seen in HIV-negative classic Hodgkin lymphoma. We could also see that there were fewer CD57 positive cells and fewer CD123 positive plasmacytoid dendritic cells in HIV positive classic Hodgkin lymphoma. Thereby, all these suggesting that the EBV, the infectious agent, plays a role in controlling the microenvironment. Similar differences we saw with post-transplant diffuse large B-cell lymphomas. Here is a comparison of post-transplant diffuse large B-cell lymphoma with diffuse large B-cell lymphoma in an immune-competent patient. You can see that there were more immune cells, particularly CD8 positive T cells in post-transplant diffuse large B-cell lymphoma. And these cells looked much, they were larger, they looked more stimulated, and these T cells, CD8 positive T cells, were not infected with EBV. They were bystander cells. And then because these cells were larger and they looked more atypical, we went on to look at clonality of these cells. And we could show that in a significant proportion of EBV positive post-transplant lymphoproliferative disorders, there were expanded T cell clones. Like you can see in monomorphic PTLD, nearly 70% of them had expanded T cell clones. And these, we believe, is because of a limited repertoire against the EBV positive, EBV infected lymphoma cells. Similar to what we have seen with EBV, similar processes occur with the KSHP, HHV8 associated lymphoid proliferations. There are key molecules, oncoproteins produced by the virus, like the LANA, like the cyclins and the FLIP and IRF3, which are produced by the HHV8 virus, which can lead lymphomagenesis in this group of diseases. When we look at all the lymphoid lesions associated with infectious agents, we see that they have varied clinical aggressiveness and disease biology. So all of them are not the same. At one end, we have self-limiting diseases like infectious mononucleosis or relatively benign diseases like EBV positive cutaneous ulcer or HHV8 positive germinotropic LPD. And at the other end, we have highly aggressive lymphomas like Burkitt lymphoma, plasmablastic lymphoma, primary effusion lymphoma, and HHV8 associated diffuse large B-cell lymphoma. And then in between, we have some polymorphous lymphoproliferative disorders and some of the conventional lymphomas like EBV positive diffuse large B-cell lymphoma, classic Hodgkin lymphomas, so on and so forth. As these are of varied aggressiveness, this also brings in an issue of overdiagnosis. The borders between like what is ABV positive cutaneous ulcer, what could be a lymphoma can be tricky, what could be a polymorphous LPD versus what is a lymphoma can be tricky, so on and so forth. So I'll just take you through some of these entities to understand the pathology and the diagnostic difficulties that one might face. EBV positive mucocutaneous ulcer is a circumscribed, painful, shallow ulcerative lesion frequently occurring in the oropharyngeal mucosa, skin, or in the gastrointestinal tract. Many of these patients have these patients can have different types of immune suppression. It could be medication-associated immune suppression of age-related immune senescence. It could be autoimmunity, or it can be post-transplantation related immune suppression. Many of these, or sometimes it can even be other cancer, like some patients of lymphomas can also have mucocutaneous ulcer. So the important thing about this is that some of these could regress spontaneously, or they could respond to withdrawal of the immune suppression the patient is on, or which will help in immune reconstitution. So morphologically, this has got a polymorphous infiltrate. You got atypical large B cells, which can look like Hodgkin cells. They show strong CD30 expression. They are always EBV positive. About 1/2 of them can even express CD15. And some of them, they frequently express OCT2, but they often lack BOP1. Some of these, so because of these reasons, some of these can be mistaken for classic Hodgkin lymphoma. But one should remember, extranodal presentation, particularly in the GI tract of classic Hodgkin lymphoma, is almost unknown. So if there is a lesion which looks like classic Hodgkin lymphoma at a mucosal site, consider whether this could be EBV positive mucocutaneous ulcer. They often showed CD20 expression at reduced levels, and they show abundant T cells in the background. They can be clonal immunoglobulin gene rearrangement. They can also, like I showed you in the PTLD setting, they can have restricted or clonal T cell expansions, and nearly 1/2 of them spontaneously regress. This is a typical feature. This was one of the first publications on this, which came from Stefan Doshnikov, showing a superficial ulcerated lesion, and the tumor cells are seen superficially in the ulcer bed, and deeper within the ulcer, you see a band of T cells. The blue portions of this ulcer are usually small lymphocytes full of CD3 positive T cells. They can show necrosis, and you can get clonal expansions of B cells or T cells, and these usually are both EBER and EBV-LMP1 positive in this case. The next entity, which is which one should think about, is a polymorphic lymphoproliferative disorder arising in immune deficiency or immune dysregulation. When I change, in the current WHO classification, these are called polymorphic post-transplant lymphoproliferative disorders, and the current WHO also mentioned that rarely this can be seen in the setting of HIV, but one should remember that similar things can be seen even outside of the transplant setting or the HIV. In any kind of immune deficiency setting, one could see a polymorphous lymphoproliferative disorder. So one has to keep this entity in mind when they look at a polymorphic infiltrate of cells. The architecture is usually, this can be distinguished from an infectious mononucleosis like proliferation, because the architecture is a phase. There's a heterogeneous population of cells, polymorphic cells, which is composed of both B cells expressing a full spectrum of B cell differentiation. Along with that, you have T cells, plasma cells, and other cells which are not part of the proliferation. And the large B cells can have a Hodgkin-like morphology, and EBV is positive. Some people also bring up the question whether they can be EBV negative polymorphous LPDs, but I think that's much more difficult to recognize even if they exist. So currently, it is defined by EBV positivity, and EBV and these proliferations can be monoclonal or oligoclonal. Both nodal and extranodal presentations can occur, and some of them can also present with HLH. I'll take you through a few examples, which also brings in the question of diagnostic difficulties in this case. This is a patient, woman in her 60s, which I saw when I was in London, treated with for pancreatic cancers, cancer of 2 years prior to the current presentation. Patient had complete remission of pancreatic cancer, then also got treated for a neuroendocrine carcinoma, neuroendocrine tumor in the sinonasal area. Patient presented with fever and weight loss of 3 months duration, And patient had a large paralytic mass of 7 centimeter dimension, and then also had right axillary lymphadenopathy. And we got a needle core from the axillary lymph node. And as you can see here, it's a polymorphous infiltrate. And I'll just focus on 2 areas of this lymph node. One of the areas showed predominantly medium-sized atypical lymphoid cells with some histiocytes. And other part of the lymph node, we had cells resembling Hodgkin cells, mononuclear Hodgkin cells, some of them looking more mummified and with a very large nucleolus. And when we, here is most of the cells were CD3 positive. The medium-sized cells were all CD3 positive. And you can see there were many EBER positive cells, and these EBER positive cells included both the large cells and many of the medium-sized atypical cells. And most of the T cells were a mixture of CD4 and CD8 positive cells with a slight preponderance of CD8 positive T cells over CD4 positive cells. And the largest cells typically were CD20 positive, they were OCT2 positive, 15 and 30 positive. And this is the EBER, a lower magnification, to show you that there are large cells or looking like Hodgkin cells, which are CD30 and CD15 positive, which were EBV positive. But in the background, there were a large number of small to medium-sized cells, which were also EBER positive. These cells were CD30 negative, CD15 negative, and they were all T cells. Here is a double stain with CD3 in red and EBER in brown. You can see the large Hodgkin-like cell, which is EBER positive, but negative for CD3. But the background cells, many of the EBER positive cells are CD3 positive. And when we further evaluated this, these cells were CD8 positive, EBER positive, whereas the large Hodgkin-like cells were negative. The medium size and smaller EBV positive cells were CD8 positive. And then we tried to do gene rearrangements in this. The T cell receptor gene rearrangement was polyclonal. We couldn't evaluate the immunoglobulin gene rearrangement. So basically, in this case, we saw 2 processes. One was there was a chronic active EBV infection, primarily involving the T cells, and in the background of that, we had a polymorphous LPD developing, which with some features resembling Hodgkin lymphoma. So it was a polymorphous LPD along with a chronic active EBV infection in the T cells. There's another case here, which is a 60-year-old man who presented with mild pancytopenia. And the questions were whether the patient has, is this an infection, or whether the patient has hemophagocytic lymphohistiocytosis. The bone marrow aspirate was hypercellular. There was no obvious dysplasia, there was no lymphoma, and no definite hemophagocytosis was seen. But on the flow, we saw that there were increased number of TCR gamma delta T cells, and these cells were slightly larger. And here is a flow plot, just focusing on these cells in red. These were larger cells, the slightly higher site scatter. These were gamma delta T cells, which were negative for CD4 with weak CD8, and these were CD5 negative, and there was some CD56 expression. So typical gamma delta T cells with CD56 expression, lack of CD5, lack of CD4, and low expression of CD8, low to negative expression of CD8. And in the bone marrow co-biopsy, you can see there is some increased lymphoid cells, but nothing very dramatic. Higher magnification to look at these lymphoid cells. There were many T cells which looked like normal T cells, but there were some T cells which were larger. And when we look at here in a close-up look at these cells, these were the medium-sized, slightly larger T cells, and these were EBV positive. And here is a double immunostain to show that these were not only CD3 positive, here and they were also CD56 positive, EBER positive, gamma delta T cells. And the EBV serum load waxed and waned in this patient. And these were the positive cells were CD3 positive, CD3 gamma delta positive, 56, 57 granzyme B, and also CD30 was positive in a proportion of cells. So this is a case of, and in this particular case, we could establish that there was a monoclonal expansion of TCR gamma by TCR gamma gene rearrangement. So this is a case of chronic active EBV infection of the T cell type of gamma delta subtype. So, I mean, when you see EBV positive lymphoid cells in a tissue biopsy, I think we have to keep a very wide differential diagnosis, and we have to carefully evaluate whether EBV positivity is in typical Ristenberg-like cells, whether they are in large B cells, or whether they could be in T cells, and that distinction is quite important. And when you see EBV positivity in many smaller B cells in what may otherwise look like a Hodgkin lymphoma, one has to be more careful that some of them may not actually be a Hodgkin lymphoma. In Hodgkin lymphoma, EBV positivity is typically seen in large cells. We move on to the next entity, which is EBV positive diffuse large B-cell lymphoma. To call it, the definition of this disease is that patients should not have a previous history of another lymphoma, and should not have any kind of immune deficiency. Although most of these patients are elderly, age is not a criterion for diagnosis. And it should not fulfill the criteria for any other EBV positive lymphoproliferative disorder or a lymphoma. It should not be a polymorphous lymphoproliferative disorder. It should not be a plasmablastic lymphoma. It shouldn't be a EBV positive lymphomatoid granulomatosis. So all those things need to be excluded before we coin a case as EBV positive diffuse large B-cell lymphoma. Most patients are over the age of 50. Typically, the peak is in the 6th, 7th, and 8th decade. And the proportion of EBV positive DLB cells as a proportion of all DLB cells increases with age. And around 25% of the people above the age of 90 are EBV positive diffuse large B-cell lymphomas. Overall, it accounts for about 10% of DLBCLs. But these patients usually have a high IPI and a high ECOG score. And again, like in the, as I mentioned, EBV, compared to EBV negative diffuse large B-cell lymphoma, they carry a lower mutational load. And there are, as I mentioned earlier, there is recurrent alterations of the NF-κB, Wnt, and IL-6 JAK-STAT pathways. They often show PD-L1 overexpression, and many of them have structural variations in PD-L1 and PD-L2 genes. Morphologically, they can look more polymorphous. That's why they have an overlap with the polymorphous LPD, and one has to carefully evaluate the case. But many of them can look extremely monomorphic. They may look no different from diffuse large B-cell lymphoma. So properly classifying every diffuse large B-cell lymphoma needs to be evaluated for EBV to dissect out EBV positive large B-cell lymphoma from DLBCL NOS. In the polymorphous category, you have large transformed cells admixed with other cells like small lymphocytes, plasma cells, histiocytes, and epithelioid cells. Often you can see coagulative necrosis, you can see an angiocentric pattern. And you can also, these often have an activated B-cell phenotype or a non-germinal center phenotype. They can express CD30 and CD15. So one has to remember, one should not mistake these as classic Hodgkin lymphoma. They often have type 2 or type 3 latency. By type 2, they express EBV LMP1, and type 3, they also express EPNA2. And in the Western countries, it's not clear how, independent of age, how EBV positive diffuse large B-cell lymphoma has whether it has any impact on patient outcomes. But in Asia, particularly in the Far Eastern, East Asia, like Japan or other places, EBV positive diffuse large B-cell lymphoma has worse prognosis as compared to EBV negative diffuse large B-cell lymphoma. Here is a typical case. Here you can see a polymorphous population of cells, a diffuse infiltrate with areas of necrosis. And you can see the vascularity is quite prominent. There's a mixture of granulocytes, histiocytes, along with the large neoplastic cells. And these are CD20 positive, EBV positive. Histiocytes are highlighted with CD68R, and a significant number of CD5 positive T cells. We can demonstrate the kappa light chain restriction in these cells. They have a high proliferation, and they are almost always express MUM1. CD10 is almost always negative. BCL6 may or may not be positive. In contrast to the case which I just showed you, here is another case, which is a 70-year-old female patient presented with a left adrenal hemorrhagic non-functioning tumor. That was what it was described as. And on gross examination, it's a 22 centimeter mass, which was a pseudocyst, hemorrhagic pseudocyst with brown fluid. I think we took about 20 or 25 blocks from this. in a few blocks within the fibrin, we had these large abnormal cells. And here is the adrenal, here is the large abnormal cells within the fibrinous areas. And these, you can see these are quite atypical looking large lymphoid cells, which were uniformly EBV positive. There were very few T cells or any other reactive cells. And these were CD20 positive, MUM1 positive, T67 was quite high. And though this may morphologically look like a diffuse large EBV positive diffuse large B-cell lymphoma, one has to be aware that this can occur in areas of fibrin, and this has a completely different behavior and outcome. So this is what we call fibrin-associated diffuse large B-cell lymphoma. Most often they are EBV positive, very rarely they can be EBV negative. So you find dense fibrin around tumor cells, and infiltration of the pre-existing normal structures are usually absent. In this case, the adrenal itself was not infiltrated with the lymphoma cells, and these have immunoblastic morphology. Free mitosis and apoptosis are quite frequent. Inflammation or reactive T cells are extremely sparse. They can also rarely express CD138, and this connects very good clinical outcome. Excision itself will be sufficient in these patients. Plasmablastic lymphoma, many of you are aware in India, it's not uncommon. It results in, usually seen in HIV positive patients, results in diffuse immunoblastic proliferation of tumor cells having plasmacytic features, typically present in oral cavity. This was where Harold Stein initially described in oral cavity and mucosal slides, but can involve other mucosal slides like the sinonasal area. It can involve orbit, skin, bone soft tissues, and also lymph nodes. It can also, though most of them occur in the HIV setting, it can occur outside of the HIV setting in any situation where immune suppression occurs, like in a post-transplant setting or an autoimmune setting. And rarely it has also been described in patients who have received CD19 CAR T cell therapy. Usually these patients have advanced stage and they have a high IPI. Around 60% of them are EBVs. In my experience, most of them, more than 80% of them, or 90% of them are EBV associated. And in the HIV setting, more than 80%, or 80% of them are EBV associated in the literature. But I think in my practice, the very rare cases I've seen which are EBV negative. They typically have a latency type 1, but rarely they can have type 2 latency with LMP1 expression. Again, most of them in the literature, around 80% in the literature, have mixed translocation. In my practice, more than 95% of them have mixed translocation. They often express most of the plasma cell markers like CD138, CD38, BLIMP1, MUM1, XBP1. These are all expressed in plasmablastic lymphoma. Importantly, they are negative for the conventional lymphoma markers, conventional B-cell markers. CD45 is negative, CD20 and PAX5 are negative. So one may not immediately recognize this as lymphoma. Like in any other plasma cell tumor, there is light chain restriction, the light chain expression and light chain restriction in most cases. One of the issues would be how to distinguish this from a plasmablastic myeloma, plasmablastic plasmacytoma. Initially, one thought that CD56 may be helpful, but a proportion of plasmablastic lymphomas, a minority of plasmablastic lymphomas express CD56. So CD56 expression is not always useful in making the distinction. Expression of cyclin D1 definitely does not go in favor of a plasmablastic lymphoma, whereas plasmablastic myelomas, a significant proportion of them are cyclin D1 positive. These also express MYC because most of them have MYC translocation. MYC protein is expressed in these cases, and quite often PD-L1 is expressed. They often show loss of MHC class II antigens, and they have a very high proliferation. Here is the typical morphology of a plasmablastic lymphoma. These look like immunoblasts with plasmacytic differentiation, plasmacytic features, and they uniformly express CD138, EBV is positive, and you can very easily demonstrate light chain restriction. In this example, it is kappa light chain restricted. We move on to the next entity, which I want to discuss is the KSHV or HHV associated multicentric Castleman disease. So this is not a malignant lesion, but behaves in a clinically aggressive manner. Most patients are HIV positive, more than 80% patients. The median age is around early 40s. And most of these patients are on antiretroviral therapy, and HIV viral load is quite low, and CD4 counts are reasonably good. Rarely it can occur in HIV negative patients, and these patients tend to be older, in mid-60s. It has a male predominance, and the lymph node morphology has features of a mixed pattern of Castleman disease, like the follicles can look like the hyaline vascular type, and there's an abundant plasma cells in the background. But the defining feature of this disease is the presence of what we call plasmablasts. These are medium to large size cells with 1 to 2 nucleoli and moderate amount of amphiphilic cytoplasm. And these are typically seen in the mantle zones, but can also be seen outside of the mantle zones, either within the germinal centers or in the perifollicular areas. Importantly, one has to realize that these lymph nodes, more than half of them have microscopic foci of Kaposi sarcoma. It's important to recognize this, report it, tell the clinician that there is Kaposi sarcoma, because at that time, patient may not have typical skin Kaposi sarcoma. And when these patients are treated for multicentric Castleman disease with rituximab, some of them can have a flare of their Kaposi sarcoma. So it's important that the Kaposi sarcoma is also treated along with multicentric Castleman disease. The plasmablast density can be quite variable. They are typically positive for MUM1 and BLIMP1. CD20 initially was reported as being negative, but they usually dim. The proportion of cells can show. I will demonstrate that. And they typically lack plasma cell markers like CD138. They are IgM positive, they are lambda positive. So they are lambda light chain restricted, but they are not monoclonal. They are monotypic, but not monoclonal. If you do immunoglobulin gene rearrangement, they are monoclonal in their pattern. And in the serum, you can always detect increased copy numbers of KSHB or HHV DNA. This is a classic example. You can see a lymph node where the follicles with their thick walled blood vessels entering them have features like what one would see with angiofollicular or hyaline vascular type of Castleman disease. But outside, you see abundant reactive plasma cells. And the follicles can be highlighted with CD21. But the important cells here are these cells within the mantle zone areas. These are the plasmablasts. These are large cells with nucleoli in the mantle zone areas. And these are HHV8 positive, typically in the mantle zones. And these are IgM positive. They are lambda light chain positive and kappa light chain negative. As against the plasmablast, those plasma cells in the interfollicular area, they are polytypic. They are positive both for kappa, and some of them are positive for kappa, some for lambda. So these are polytypic. The interfollicular plasma cells are polytypic, but the cells, the plasmablast in the mantle area is monotypic for lambda light chain. So as I said, initially people reported that CD20 is negative, and it was a perplexing thing how these patients responded so well to rituximab. So we started doing some amplification of CD20 and double stains with CD20 and HHV8, and we could show that these cells indeed express CD20, but the CD20 expression can be very variable, can be very low, and some cells here, like you see HHV8 positive cells expressing CD20, and some cells it almost looks negative or looks very weak, and some look completely negative. But we could show that CD20 expression is indeed seen in the plasmablast, albeit at a very low level, and that's why these patients respond to rituximab treatment. Then another unusual feature we saw in these patients were in a subset of cases of multicentric Castleman disease, we could see HHV8 LANA positivity on the FDC processes. The FDC processes, we could see HHV8 LANA positivity on the membrane, but not in the nuclei of the follicular dendritic cells. So this was some intriguing finding. So here where HHV8 is colored in brown and CD21 is colored in red. So then because a subset of multicentric Castleman disease had this feature of FDC processes being positive for the HHV8 LANA protein, we wanted to see what it would associate with. To our surprise, what we saw, cases where the HHV8 LANA positivity was seen on the FDCs, there were fewer number of LANA positive plasmablasts, whereas those where we did not see the FDC expression, FDC positivity for LANA protein, we had more plasmablasts. Also, when we looked at the number of T cells, these where the FDC processes were positive for LANA had more numbers of CD3 positive T cells, whereas those where the FDC processes were negative for LANA had fewer CD3 positive T cells. We also showed that in about 60% of cases had this kind of microscopic Kaposi sarcoma, often seen in the capsule or in the trabeculae. And as I said earlier, recognition of this feature is important while you're working up cases of multicentric Castleman disease. Multicentric Castleman disease, as I said, in most cases, more than 90% of cases, the plasmablasts are polyclonal. It is still a reactive condition. Some of them may develop into different types of lymphomas. One of the lymphomas that these patients can develop is primary effusion lymphoma. Here you have lymphomatous serous effusions, without most of them present with serous effusions without any solid tumor mass. But some of them can present with a solid tumor mass, which what we call as an extracavitary primary effusion lymphoma. These patients usually have a low CD4 count, and very rarely this can also be seen in setting outside of the HIV, like the post-transplant setting or in elderly patients. In the HIV patients, it's usually seen in median ages around 40 to 50, and in the endemic areas like sub-Saharan Africa and Mediterranean, you can see this in older people, where HHV8 positive disease is seen in an endemic fashion. And they're often accompanied by Kaposi sarcoma, and 50% of them may also have Castleman disease at the time when they present with primary effusion lymphoma. The key feature of this disease is the lymphoma cells are co-infected by HHV8 virus and the Epstein-Barr virus, though the pathogenesis is predominantly driven by HHV8. So you can demonstrate these presence of the virus using HHV8 LANA1 antibody and EBER in situ hybridization. Typically, EBV LMP1 is absent because what you have for EBV is a type 1 latency. These again are the tumor cells appear large. They are immunoblastic type or plasmablastic type, and frequently quite anaplastic looking. They typically express CD30, CD38, and some of the plasma cell markers like 138, VS38C, BLIMP1, and MUM1. And they're negative for many of the lymphoid markers, including CD45, most of the B cell markers, OCT2-BOB1, and immunoglobulin. So an important difference from plasmablastic lymphoma is that the primary effusion lymphoma does not express immunoglobulin. And you can have aberrant T cell antigen expression in nearly 30% of cases. Here is a typical primary effusion lymphoma, extracavitary type, presenting as a solid tumor mass. Here you got anaplastic large cells, which are very cohesive. This case was CD45 positive, but it expressed other plasma cell markers like MUM1 and CD38. CD79A was all other B cell antigens were downregulated. CD79A was positive in an occasional cell. CD30 was present in significant proportions of cells. But importantly, this was co-infected with EBV and HHV8. Here is EBER in situ hybridization. Here is HHV8 LANA, but both are positive in these tumor cells. Many of these primary effusion lymphoma samples overexpress PD-L1. They show a strong expression of PD-L1, and some also express PD-L2. There is also another entity which is rare. A small minority of patients of multicentric Castleman disease go on to develop HHV8 positive diffuse large B-cell lymphomas. This is singly infected. This is not infected with EBV. So these patients have profound immune deficiency. Most of them are HIV positive. They are consistently positive for HHV8 or KSHV. They characteristically involve lymph nodes and spleen, and tumor cells are large and aplastic. They're variably positive at 45 and 20. Most often 20 is negative, like in multicentric Castleman disease. And like in multicentric Castleman disease, these show cytoplasmic IgM expression on lambda light chain restriction, But in contrast to the classic multicentric Castleman disease, these are monoclonal, whereas multicentric Castleman disease is monotypic, but polyclonal. Here, the tumor cells are monotypic and monoclonal. So they are positive for HH-V8 LANA, they're positive for viral IL-6, they're positive for MUM1, and they're often negative for 138. Remember, 138 is negative also in multicentric Castleman disease. So it maintains many of the features of multicentric Castleman disease, but it becomes monoclonal. So it's a kind of an evolution from multicentric Castleman disease to HH-V8 positive diffuse large B-cell lymphoma. There is another entity which is an extremely rare entity. I do not know how often, how many people would be able to see. I mean, I have only seen this in collections, and one of the cases was shown to me by Peter Isaacson from his practice long ago. What we call as HSV HH-V8 positive geminotropic lymphoproliferative disorder. These are elderly patients who are HIV negative, often presenting with neck lymph nodes and no other symptoms, a very benign presentation. The germinal centers are partially or completely replaced by sheets of plasmablastic immunoblastic cells, which are co-infected with HV8 and EBV. So these have gotten, the phenotype of this is very similar to primary effusion lymphoma, but the location of the tumors of the abnormal cells is entirely within the germinal center. It's limited to the germinal centers. So these are MUM1 positive, CD38 and EMA positive, and occasionally 138 positive. But as against the primary effusion lymphoma, many of these, nearly 2/3 of them, have monotypic immunoglobulin expression. And these patients, but when you do PCR analysis, these are polytypic. So again, these can be monotypic for light chain expression, but they are polyclonal, and it has got excellent survival. Another disease which can happen in HH-V8 positive patients is hemophagocytic lymphohistiocytosis, which is quite an aggressive presentation. It occurs in about less than 10% patients of multicentric Castleman disease, often in the bone marrow, and some patients even undergo splenectomy. We can see HH-V8 positive plasmablast-like cells, and in the background of those, you see histiocytes with active phagocytosis. And patients have high viral IL-6, and you also have patients have high IL-8 and interferon gamma, and the presentation is quite acute. In the last few slides, I will touch on adult T-cell leukemia lymphoma, which we see in small numbers. We don't have a huge experience with this disease, but we see in small numbers. Clinically, these are considered into 4 variants: the acute leukemic type, or the acute type, the lymphomatous type, and you have the chronic type and the smoldering type. It's important to recognize that these have got genomic correlates. The acute and lymphomatous type, which are the aggressive ones, they have a higher burden of genomic and epigenetic alterations. There is more frequent TP53 and IRF4 mutation, and the copy number changes are also more in these aggressive types. Whereas the indolent type, the chronic and the smoldering type, is also frequently associated with STAT3 mutation. Japanese workers who have worked a lot on ATLL have also come up with a genomic score of group 1 and group 2, which also which have differing outcomes, but also has correlation with the clinical subtype that I just described. What is important is that when you see a T-cell lymphoma case, it is important to evaluate the patient for HTLV1, because there are many HTLV1 positive ATLLs which can masquerade as any other T-cell lymphoma. Patients which are classified as mycosis fungoides, patients which are classified as peripheral T-cell lymphoma, may actually, a small proportion of them may be ATLL, and their behavior may be completely different. And this is a study which came from Miami, where they showed that in many cases of ATLL, it could look like any other common T-cell lymphoma. So one of the rule of thumb that I practiced in the UK was that every single patient of T-cell lymphoma, we would evaluate for HTLV1. And I try to continue the same practice here in the US. I'll just share with them a couple of cases of ATLL. Here is a patient, an HIV positive patient in his 60s, who was referred to Hammersmith Hospital for allogeneic stem cell transplantation. By that time, patient had already received 2 courses of ICE. And Then here you can see these large abnormal cells in the bone marrow. And these cells were CD3 positive, CD4 positive, CD25 positive. Often these cells are CD25 positive, which is a useful marker both by immunohistochemistry and by flow. And an occasional cell looked, I mean, there was some CD8 positive cell, but most of the abnormal cells were CD4 positive. And we could demonstrate the TCR gamma rearrangement, monoclonal rearrangement, and the patient was HTLV1 positive. So this is a typical case of ATLL. Here is the flow cytometry on this patient, where the red population of the ATLL cells population, which is CD3 weak, CD2 slightly stronger, and then CD7 again is a bit weaker in this population. CD25 is also positive in a subset of these cells, and CD8 is mostly negative. I mean, this need to be separated from chronic carriers of HTLV1 virus. Here is a patient with HTLV1 carrier, which, I mean, these look very similar to the ATLL cells. Here you can see that these are CD3 weak, and they are CD4 positive, CD8 negative, CD5 weaker than the normal cells, and then these were CD25 positive and CD26 negative. And when we did TCR gamma rearrangement, we found an oligoclonal expansion and not a monoclonal expansion. So distinction of these HTLV1 carriers from ATLL cells, ATLL type, these cells have many of the features of ATLL, but these are oligoclonal expansions. And when you look for HTLV1 virus itself, again, those are oligoclonal. There is no monoclonal integration of the virus into the lymphoma cells in the carrier states. Whereas in ATLL, in the lymphomatous state, they are monoclonally integrated. The virus is monoclonally integrated within the lymphoma cell population. So with this, I just want to give you an update what's going on with the WHO classification. By the end of this year, we will have the next edition of the WHO classification. Currently, as many of you may know, the WHO, how the blue books are brought out. This is managed by a tumor editorial board, which has got a chair. Many of you may have met the chair of the WHO classification, Ian Cree. I know he has visited India. The WHO committee has got standing members, and these are members nominated by various societies which are involved in cancer diagnostics, and these standing members serve for a term of 3 years. But each of the blue books has an expert editorial board and with many members, and who serve specifically for that particular blue book. And these members can serve on 1 or 2 blue books, but not beyond 2 books. And all these members collectively contribute to the development of the proceedings of the blue book. And members are chosen based on their expertise. And another important factor is that there is geographic representation on the editorial board. Members from all across the world are included in the editorial board and in the authorship. So with regards to the WHO blue book on hematolymphoid tumors, we got 25 expert editors. We got 380 authors coming from 31 countries. And among these 380 authors, not all of them are hematopathologists. A significant proportion of them are clinicians, hematologists, genomic experts. So it's a mixture of hematopathologists with other groups who have an interest and expertise in heme malignancies, clinicians, genomic specialists, clinical hematologists, all working together to bring out this book. So currently, I'm one of the 15 expert editors on that particular volume. Currently, we started working on this book in February 2021 when they announced they identified the expert editors. We had the first meeting in April, which was more like a pre-meet in April. But the first meeting we had somewhere around June. And then from July onwards, we started working on the contents of this book. We had a meeting in November where we have discussed the first drafts of all the chapters that have been written. And we are fine-tuning the chapters. We recently met in January to go over the further edits that have happened. We're going to have one more editorial report sometime in May or April or May, and we intend to bring the online version by October of 2022 and the print version by November 2022. So by the end of the year, all of you should have a copy of the 5th edition of the WHO book. Thank you.
Thank you, Dr. Naresh, for that masterly presentation. Wealth of information. Enjoyed it. We have a lot of Indian colleagues here who will be asking you some questions and interact. We will use the raise hand sign. Meanwhile, I'll just put one question. In fact, we have covered this, but there is a question from Dr. Kannan from the audience. And this is about plasmablastic lymphoma, EB virus negative, HIV negative. How will you differentiate from plasmacytoma? If there is a localized disease, is it just by morphology or there are IHC features?
Yeah, I mean, this is a diagnostic challenge. We time and again, we face this problem. As I said, I would use markers like cyclin D1. If cyclin D1 is positive, I would definitely take it as a feature favoring a plasmablastic a plasma cell tumor. If cyclin D1 is negative, that again doesn't help the distinction. And some cases you may end up calling it as a gray zone between plasmablastic lymphoma and plasmablastic plasmacytoma, plasmablastic myeloma, depending on whether it is a single site disease that bone marrow is involved or not involved. Because plasmablastic lymphoma can also involve the bone marrow. So in some of these, in HIV negative, as you described, HIV negative, EBV negative diseases, one has to be careful. Another feature that people tend to call tumors with prominent nucleoli as plasmablasts. I think if you look at the original descriptions of what was called a plasmablastic myeloma, not only the nucleolus has to be prominent, the chromatin has to be fine, and the NC ratio, nuclear cytoplasmic ratio, has to be high. So one has to keep that in mind while considering a plasmablastic plasma cell tumor. One should not just go with presence of a prominent nucleolus, because in many plasma cell tumors, the nucleolus can be prominent.
Thank you, Naresh. Dr. Jay, your question.
Yeah, hi. So it's a continuation of the same question. I find that a lot of these plasmablastic lymphomas are OCT2 and BOB1 positive, and they're not PAX5 positive. Would that help? I don't know how plasmablastic myelomas would react with OCT2 and BOB1.
I mean, normal plasma cells, because they have a normal immunoglobulin machinery, they're OCT2 and BOB1 positive. So that is not going to help. And similarly, PAX5 is downregulated
in both of them,
in normal plasma cells. So that distinction, unfortunately, doesn't help.
Okay. Is there any role for PDL1 in any of these, or even, for example, in do you use it for Hodgkin lymphoma, gray zone lymphoma? Does it help, or it's just not very useful?
Yeah, I don't know whether, I think this publication came from Girish, who used to work with us, where he showed in classic Hodgkin lymphoma, they are frequently PDL1 positive, GATA3 positive, as against many other mimics of classic Hodgkin lymphoma. I have used that in some difficult cases.
So versus like a gray zone or a distinction between a AITL having CD30 blasts, would PDL1 help in those cases?
Yeah, I mean, I've used in cases where, the cases where I have used, but some of them were PAX5 positive or PAX5 almost negative. So distinction between whether, and the problem with Hodgkin lymphoma is many times they also express T cell markers. One of like CD4 can be positive, some of the, and PAX5 can be so weak. And in those kind of cases, all these soft features are helpful. I mean, these features should be very, one should use in when everything else fails. The classic features of whether CD45 is positive, and those are the first line of defense and the first line of the algorithm.
Thank you, sir.
Thank you, Jay. One question from audience. Dr. Jayasudha wants to know experience of plasmablastic lymphoma in children?
I have limited experience with pediatric lymphomas. I can't answer this question because I haven't seen a plasmablastic lymphoma in a child, but that doesn't mean that it does not occur in a place where HIV is endemic, where you see HIV in children. It may well be seen, which I haven't come across.
She also wants to know, have you seen serum monoclonal protein in plasmablastic lymphoma?
Yes, of course, yeah. You can get monoclonal immunoglobulin in plasmablastic lymphoma.
Dr. Parimal, your question.
Sir, excellent talk. Sir, my question is related to PDL1. Whether in EBV positive DLBCL, we have to do PDL1 in each cases of DLBCL with high-grade features, and we do PDL1, and which clone is SP263 we have to do, or?
Oh, okay. First of all, I don't do PDL1 in all the cases. PDL1 I have either used as a part of research where I was looking at primary effusion lymphoma and plasmablastic lymphoma. But in my routine clinical practice, I use PDL1 when there's a likelihood that the patient is going to be treated by, anti-PD1 or PDL1 antibodies. So it's more of a therapy-related thing, and rarely in the setting of Hodgkin's and the differential diagnosis, or in primary mediastinal large B-cell lymphoma, where I have used it for diagnostic purposes. So in Hodgkin's and primary mediastinal large B-cell lymphoma, and probably most of the primary mediastinal large B-cell lymphoma, because you always have that question whether it is some diffuse large B-cell lymphoma presenting in the mediastinum. So I tend to use PDL1, CD23, all those things as a useful diagnostic feature. But otherwise, I would do it more for treatment purposes.
PDL1 is negative in primary mediastinal large B-cell lymphoma.
No, it's positive. Often primary mediastinal large B-cell lymphomas have translocations close to PDL1 and PDL2 region. So they overexpress PDL1.
Thank you.
Thank you, Parimal. Dr. Ashwin Das.
Yes, thank you, Dr. Naresh, for really nice lecture on the virus-associated lymphomatous process. I just want to have you can say the comment, why lymphomatoid granulomatosis cannot be put under a special variety of DLBCL? And is it just a nomenclature problem, or is it really a extranodal site predominance and waxing and waning angiocentric or angiodestructive property? It has been kept separately, or is there any need to put it inside the DLBCL?
Okay, in the current, at least in the upcoming WHO classification, 5th edition, under the broad umbrella of large B-cell lymphomas, you have, 12, 13 entities are there. And one of them is lymphomatoid granulomatosis. So the reason that it still needs to be distinguished from DLBCL NOS is because to come to a diagnosis of DLBCL NOS, you need to exclude all these things. But it is still under the umbrella of a large B-cell lymphoma.
Okay. But I think in DLBCL, we don't have any grading system. At least in lymphomatoid granulomatosis, you have a
grading system.
So grade 3 may be towards the DLBCL, but grade 1 and grade 2, still they have some logic to keep it separately from DLBCL.
I mean, the grade 3, the distinction is from an EBV positive DLBCL.
Yes. Yes.
And the reason why EBV positive DLBCL is distinguished from lymphomatoid granulomatosis grade 3 is because of typical clinical presentation in the lung, presentation in the kidney, the classic clinical, multiple nodules in lung, which the EBV positive DLBCL does not present in that manner.
Okay, thank you.
Thank you. Question from audience. Dr. Manasi wants to know, will CMYC help in distinguishing between plasmablastic lymphoma and plasmacytoma?
A small proportion of myelomas also can have MYC translocation. So for that reason, it does not help. So, but I would do a MYC protein expression as a part of my panel of any large B-cell lymphoma. That helps me in other ways, but the specific question whether it's going to help in distinguishing myeloma from plasmablastic lymphoma, no, it does not, because you can get the same thing in myeloma.
Thank you. Dr. Tara Roshni.
Good evening. Thank you very much for the presentation. My question, it's a comment actually. In patients of Hodgkin's lymphoma in the background of HIV infection, sometimes, yes, they come with the lymph node biopsy done, but quite often we have patients presenting with long-time fever and pancytopenia, and the bone marrow is the first site of diagnosing the Hodgkin's lymphoma. Your comments on this?
Yeah, that's very true. In the HIV setting, you can get very unusual presentations. Bone marrow, many times even liver biopsy.
Yes.
The first diagnosis has been on a liver biopsy. First diagnosis has been in bone marrow. It's not uncommon. So that is something one has to keep in mind. And many patients may get treated based on the, you may not have an accessible lymph node, or lymph nodes may not be that large. So you will have to treat patients based on bone marrow biopsy.
Thank you.
Thank you. Jasmita.
Good evening, sir. It was a pleasure listening to your presentation. Sir, you showed a beautiful case of chronic active EBV infection in the bone marrow. So in what situations do you normally perform a Eberish on the bone marrow, and what are the clues to pick up this chronic active EBV infection? So we do flow for a lot of our cases. We come across these minor small increases in the gamma delta T cells or sometimes the cytotoxic T cell population. So how frequently should the marrows be assessed for Eberish in that case?
Usually, in any immune deficiency setting, I have a very low threshold for doing EBA. So that's one thing. And the second thing is any kind of HLH, any kind of even a suggestion that the patient may be having cytopenias, and HLH is on the differential diagnosis, I will do viral stains just to, because HLH is driven either by a virus or by a neoplasm, and or some other infection. You can even see with tuberculosis, you can see HLH. So I would try to exclude all types of infections and clonal populations if there is an HLH. And chronic active EBV infection, yeah, you're very right. How often do we miss that? I do not know how many cases I might have missed. I am only showing you cases where I have picked up. Okay, so maybe I have a little less threshold than others for doing these things, but I can't. If the general yardsticks are if the patient is unwell for a very long time, and often these patients might have undergone 1 or 2 biopsies before we make the right diagnosis.
Thank you. Okay, Jay. Doctor, yeah.
Yeah, hi. So switching over to the EBV MCU, in the GI tract, do you see a mass lesion on occasions, or it's always just a shallow ulcerated lesion? Part 2 of the question is, sometimes, and it's just obviously difficult to distinguish between, say, a classical Hodgkin lymphoma, but that would be unusual at a mucosal site. And on occasions also, one would think, is it a polymorphous EBV DLBL? So can you give some hints or your thoughts on how to approach such cases?
Yeah, I think you brought out a very important question, which I forgot to touch in my talk. If you see a mass lesion and you have a morphology looking like a mucocutaneous ulcer, I think you have to be very careful, ask for repeat biopsies. In the GI location, if there is a mass lesion that does not fit with ABV positive mucocutaneous ulcer, you got to go for deeper biopsies. And you may have a frank lymphoma. You may have something completely unrelated beneath that. So that's a situation where you have to be very careful. And also, rarely you can have abdominal lymph nodes ulcerating through the mucosal sites, like in Hodgkin's as well. So any mass lesion does not conform with the diagnosis of EBV positive mucocutaneous ulcer.
And your thoughts on a mucosal site Hodgkin's with no lymph nodes involved, and versus, say, how to distinguish between a polymorphous EBV associated DLBL?
Yeah, more and more people are, I think whether in a very rare situation you have a mucosal classic Hodgkin lymphoma, if it is present, it will be very anecdotal. I mean, I can't remember when I last saw a primary mucosal Hodgkin lymphoma. You can get a mucosal Hodgkin lymphoma when, like we have seen mucosal biopsies from sinonasal area, which look like Hodgkin, but even those patients, all of them turn out to have a lymph nodal Hodgkin as well. But exclusively having mucosal involvement without any lymph nodal involvement almost never occurs in Hodgkin lymphoma. So you got to think of alternate diagnosis like a polymorphous DLBCL, like you're saying.
Where do you draw the line between that polymorphous DLBL versus trying to?
Yeah, I mean, I would probably go do many things, like is it expressing immunoglobulin? In most of these cases, because they're of non-germinal center phenotype, they also have immunoglobulin expression. So you can show light chain expression in many of them. In Hodgkin's, sometimes you can get a non-specific positivity, but you have to be careful. But Hodgkin's typically will not express immunoglobulin. Yeah. J-chain is easier. You can do J-chain, which is, many people have now given up doing J-chain, which is, I think, becomes much cleaner. The other thing which I have picked up after coming to the Hutch is we do CCR7. I don't know how many of you, CCR7 almost never comes in any other disease other than Hodgkin lymphoma. All the cells are not positive, only a minority of cells are positive, and the stain is very clean. Actually, this is the work of my colleague here, Jonathan Fromm, who is again a big fan of flow cytometry in Hodgkin lymphoma. He has done thousands of cases of flow in Hodgkin's. And one of the things that he has brought to the lab is CCR7. And I'm becoming a fan of that now.
So it's expressed in the Reed-Sternberg cells and not in the
Reed-Sternberg cells. Okay. And only a minority of Reed-Sternberg cells, but I think it is not expressed in anything else.
Okay. Okay. That's a useful hint. Thank you. Thank you so much.
One question from audience. Jayasudha wants to know, any experience with EB virus positive nodular lymphocytic predominant Hodgkin lymphoma? And then how will you differentiate it from EB virus positive DLBCL?
Yeah, I mean, rarely, I mean, I've seen anecdotally 1 or 2 cases of EBV positive nodular LP Hodgkin's. In the initial phases, when these reports were not there, and I wondered whether those could represent some kind of a gray zone between classic Hodgkin and nodular LP Hodgkin's. But now I think more and more people accept that a small minority of nodular LP Hodgkin's can be EBV positive. So, but the question is whether what is the borderline between diffuse large B-cell lymphoma and nodular LP Hodgkin's, which is the same as it would be with even if it is EBV negative. Within nodular LP Hodgkin's, you have got multiple defined patterns, like pattern A to pattern F. And the T-cell rich B-cell lymphoma like nodular LP Hodgkin's is one of the patterns where you have borderline between T-cell histiocyte rich large B-cell lymphoma. So you've got to follow similar criteria. Are you seeing small B cells within the proliferation? Are there small B cells which are IgD positive? Is there any focal area with FDC meshworks? In all these, if those are there, that would favor a nodular LP Hodgkin's. And the intensity of OCT2 expression is very strongly expressed. Another thing which I have realized after coming here, the beautiful marker for nodular LP Hodgkin's is MEF2B. Again, unlike BCL6, MEF2B comes only in the germinal center B cells. Other small B cells are negative. So MEF2B is strongly expressed in nodular lymphocyte predominant Hodgkin lymphoma. So, but the question of the border between nodular LP and any form of large B cell lymphoma is not different for EBV positive versus EBV negative cases. Same dilemma is there even with EBV negative ones.
Dr. Sandeep Sheth.
Hello, excellent talk, Dr. Naresh. My question is for primary mediastinal large B-cell lymphoma. Apart from CD23, do you use other markers?
Yeah, the usual markers like CD30, CD15, no, PD-L1.
No, to differentiate from Hodgkin's lymphoma or gray zone lymphomas?
In Hodgkin lymphoma, like OCT2 and BOB1, CD45, those are my initial set. The initial set of marker for Hodgkin lymphoma I would do is CD45, CD20, CD3, CD15, CD30, OCT2, BOB1, and EBER. And EBER. EBV positivity is definitely not a feature of mediastinal large B-cell lymphoma. Again, both OCT2 and BOB1 expression would not be a feature of classic Hodgkin lymphoma. Sometimes, when you get into the gray zone, then I start using other things. Like a PDL1 again is not going to distinguish between Hodgkin and T-cell and mediastinal large B-cell lymphoma. Okay, GATA3 may be helpful in such a case. CD23 definitely,
Yes, CD23 definitely. And one more question. What about EBV associated extranodal NK T-cell lymphoma and aggressive NK cell leukemia?
Yeah, it need not be, it happens both in the lymph node and in the extranodal situation, like nasal type. They can be CD30 positive. Some of them are CD30 positive, but the phenotype, rest of the phenotype is very different. They are, cytoplasmic CD3 is positive, but when you do immunohistochemistry, they are almost always CD3 positive, but they are negative for CD5. They can be positive for CD2 and CD7 because NK cells are positive for CD2 and CD7. They're frequently negative for CD4 and CD8, but some of them can be CD8 positive. They're almost always cytotoxic molecules positive. Okay, so that distinction is not too difficult. And the morphology is quite typical. If you want to distinguish between, there's one point, using TCR beta and TCR gamma delta is useful because the NK cell lymphomas almost never express TCR beta. Rarely they can be gamma delta positive, but they are never TCR beta positive. So you have a subset of, particularly in the lymph node, what looks like NK T cell lymphoma, which is actually of T cell origin. Those are TCR beta positive. And if you do T cell receptor gene rearrangement studies, the T cell ones will be clonal for T cell receptor gene rearrangement, whereas the NK cell ones are going to be germline. They are not going to show you a monoclonal pattern.
Thank you. Dr. Rupa?
Good evening, sir, and thank you very much for enlightening us with the infection-associated lymphomas. Sir, during your talk, you showed one case of ATLL and flow cytometry plot of HTLV1 carrier. Sir, I would like to know when will we test or suspect someone to be a HTLV carrier, and how will you distinguish ATLL case from an HTLV1 carrier?
Yeah. First thing is every T cell lymphoma exclude HTLV1. But your question is between how do we distinguish between a carrier state and a lymphoma? It has to be clonality, okay? But the purest, like in the WHO class, which is coming up, you have to show the virus present in the tumor cells. If you do a Southern blot, you can show that the virus is monoclonally integrated, which we don't commonly do in most places outside of Japan. But I think there is a probe that is available for HTLV1, which I don't use, which the Japanese regularly use. Like the EBER probe, you can show that the tumor cells are HTLV1 positive. Okay, but the true way to distinguish between a carrier state and a lymphoma is to show the integration of the virus. But currently, this is done in very few places. But the other feature which you remember is HTLV1 carrier you only do from peripheral blood. You don't do it on a lymph node biopsy or a skin biopsy. So in a lymph node, you see a small population of abnormal T cells, which is CD25 positive, and the patient is an HTLV1 serology is positive, then submit the sample for T cell clonality. Most of these are oligoclonal, the ones with the carrier states.
Thank you, sir.
Thank you. One question from audience. Dr. Manasi wants to know your experience about NK T cell lymphoma. She recently had a case of CD56 lost at relapse with intestinal involvement and modest CD30 expression.
So what I understand is initially patient had CD56 positivity and later the patient lost CD56. Yeah, I mean, in tumors, many of these antigens can be lost, but unfortunately, there are not too many markers which we do on tissue sections which are specific for NK cells. If it was flow, one could have said you could use, CD14, but CD16 could be used in flow, but on tissue sections, CD57 is not specific. So one will have to resort to doing something like a CD3 showing CD3 cytoplasmic staining positivity, absence of CD4, CD8, absence of TCR beta, TCR gamma, along with an expression of CD2 or CD7. So it becomes a little more difficult. But if you already know that the patient was CD56 positive before, I think proving it is much easier. And also importantly, to show that there is no clonal TCR gamma gene rearrangement.
Dr. Shashi, unmute yourself.
Good evening, sir. It's a very good lecture, and I just get enlightened by your Hodgkin's case, where the staining for the Epstein-Barr virus explain it is the most important thing which is a differentiate between the Hodgkin's lymphoma. We have very limited setting, so I just want to know what is the technical consideration for the diagnostic modality for the Epstein-Barr virus infections related things, because it is a in situ hybridization or the ISC, which has to be done, and what is a cost-effective way of doing?
I mean, EBV LMP1 is present in latency type 2 and type 3. Yeah. Like type 1 latency, the EBV doesn't express EBV LMP1. So it depends on the disease you're looking at. If the Burkitt lymphoma, which is latency 1, it will not express LMP1. You have to do EBA. Whereas in classic Hodgkin lymphoma, which is of latency 2, EBV LMP1 is also expressed. So theoretically, all tumor samples of classic Hodgkin lymphoma will be EBV LMP1 positive. However, the sensitivity can be slightly different. Some cases, even though it is expressing LMP1, you may not be able to demonstrate it, because even in the EBV LMP1 positive case, you will see cells which may be tumor cells which may be negative. Whereas in EBO, when it is positive in almost every single tumor cell. Whereas EBV LMP1 expression is more heterogeneous. So if you're dealing only with classic Hodgkin lymphoma, you could probably be close to being accurate with just EBV LMP1. But you may still miss a few cases because of the sensitivity of the technique. But from the biology perspective, all the Hodgkin lymphoma, or most of Hodgkin lymphoma, will be expressing LMP1. But if you go to other EBV positive diseases like Burkitt lymphoma, you got to use EBA. Yeah, economically, I think LMP1 may be cheaper to do than in situ hybridization. But I suppose now with the new machines, which automated machines, I don't know, I'm probably Jay or somebody else can comment on that. Is there a big difference in the cost between doing an immunostain and an in situ hybridization? I'm not so sure.
Yeah, it's quite high, but the product is much better on the automated one with the in situ hybridization. But there is a fair amount of difference between the LMP1 stain and the probe.
I see.
It's almost 2.5 to 3 times.
Nice. Okay.
Thank you.
Thank you, Dr. Amrita.
Yeah, hi everyone. What a wonderful talk, Dr. Naresh, and thank you, Dr. Agrawal.
Thank you.
So actually, I have a question. It's first of all, I would like to know about your experience on this CCR7, because we are not using it here. And so many times there is a confusion on the morphology, whether to really think of a Hodgkin's or, those non-Hodgkin's. So I would like to know, do you really suggest that it should be incorporated in our panel of antibodies? So that's my first question. And I have another question, so maybe you can highlight it first.
After this, yes.
Yeah, CCR7, as I said, I have started using it only recently, and my colleague has been using it for a few years. And till now, what I have seen has been very encouraging. If any of you start using CCR7, please drop me an email and let me know your experience. Maybe that is something which is not best known in the literature. Maybe we could write something together. It will be, if any of you have got a tissue microarray, maybe you can just stain them with CCR7 and let us know, because I mean, till now, my experience could be skewed because I have used it in the more difficult cases, not in the easier cases. But my colleague who has worked on it for some time, he tells me that it's positive in almost every single Hodgkin lymphoma. Until now, my experience has been the same.
Okay, thank you. The next question is, like, many a times, when we get a flow sample and it's not representative. So we get stuck that we are not able to find the cells of interest in, sufficient number. And the clinicians are also sort of worried, like, what an answer they should get from us. So in such cases, what do you say, like a lymph flow cytometry on a lymph node material will be better? Because that's something like in India I have not seen. When we take out a lymph node, it usually goes to histopathology and immunohistochemistry rather than coming to us for flow cytometry. So and I don't know how practical it is. It may be a challenge, but what do you say in such cases? Is it worth like going for a lymph node flow cytometry when we are not very happy with the IHC, findings, and not getting enough cells on a flow sample of bone marrow?
Okay, are you addressing bone marrow or lymph node?
I mean, when bone marrow is not a representative specimen,
so
those cases.
Okay, if I understood you, on a lymph node, I have always made my diagnosis on a lymph node based on histology and immunohistochemistry. Having said that, after moving to here, Seattle, which is a big flow center, I'm getting more and more exposed to my colleagues who do excellent flow, including flow on Hodgkin's. So I can see the advantage that the flow can supplement even in the diagnosis in a lymph node. And I'm quite intrigued by the way, I'm looking at flow as what flow can add to what I currently do on histology. And I think even today, probably there is a lot more to do on flow than what we currently do. And maybe we have to look at flow, what added advantage it would provide, not as a replacement for what we can get from histology, but what additional things we can provide on flow. One of the obvious things that you will find is light chains. Yeah, of course you can do light chains on immunohistochemistry and it's interpretable. But maybe it is interpreted with a greater ease on flow cytometry. In more, not every lab can do good quality immunohistochemistry for light chains. And I think almost every flow lab will do good quality flow for light chains. So that's definitely an advantage. There are also some advantages on flow for some of the antigens which is not available easily on immunohistochemistry. It makes it easier. So I think if you receive lymph node in a fresh state and if the lymph node is of significant volume, I think preserving a bit of tissue for running a flow would be very useful. But I think you have to carefully choose your panels of flow. The flow has got a lot of considerations about compensation and other things. And so you got to plan that very carefully. Whereas immunohistochemistry has less of those problems. And the more the number of colors that you use in flow, I think compensation becomes even more challenging. And so you need to work with a lab which has used those panels in the past, so we can accordingly organize your flow panels.
Yeah, I understand, because I have seen Dr. Strauchen in Mount Sinai School of Medicine. He used to, do both the things. So it was very exciting to correlate the histochemistry as well as, the flow. But I know, in India, I don't know, it's really difficult to do both the things. Cost is one point. And second is difficult to get the lymph node tissue in a, desirable state. So it's still
Yeah,
a
I'm
lot.
sure in India there are some excellent flow people. Prashant Tamhare
Yeah.
from Tata, I
Yeah.
think he's excellent. Yeah.
Any experience on the FNA material from lymph node in such cases where tissue is not available, but aspiration material is there? I know
Yeah, I
it's
mean,
again difficult.
I've almost never been involved in a case which has been treated purely based on FNA. But people might argue and say, oh, why don't we combine FNA with flow and give a diagnosis? I don't feel comfortable with that.
Yeah.
I mean, I would rather combine flow with even at least a needle core biopsy rather than just with FNA.
I
I
agree.
mean, apart from, like primary effusion lymphoma, yeah, if we can have cytology and flow, that's great. But wherever it's a tissue-based lymphoma, I would prefer tissue biopsy along with flow. Yeah.
Yeah, I agree. Thank you so much.
Thank you. Dr. Tushar?
Yes, sir. Thank you, sir. So I wanted to ask about when we say that it is EBV-associated lymphomas. So how far this status of knowing the EBV status of the patient transmits to the clinical information to the clinician? Do they treat EBV because EBV is latent in the lymphomas, and they are known to cause viral activation and proliferation of the latent genes leading to lymphoma proliferation? But EBV associated lymphomas, do they give treatment which is targeted?
No. Yeah, and so currently EBV positivity helps in trying to fine tune our diagnosis. From the treatment perspective, the EBV positive or EBV negative diseases, they get the same treatment. So that doesn't differ. Second, I think one important thing I usually tell clinicians is knowing whether the disease is EBV positive helps in monitoring the patient, along with many other monitoring like imaging. One could also monitor the patient with serum EBV viral copy numbers. So you have an EBV positive Hodgkin lymphoma, you could also follow up the patient with serum EBV copy numbers. If serum EBV copy numbers start raising, that is, you may consider that a patient may be having recurrence of disease. And typically in post-transplant lymphoproliferative disorders, EBV copy number is an excellent way to monitor patients. And most patients of PTLD, they follow it that way. Whereas in other areas, people are not using that. But I think that would be an excellent tool, additive to follow up patients with. Like I showed you many chronic active EBV infection cases, EBV title, viral copy numbers, waxed and wane, and that correlated with disease activity.
Yes, thank you.
Thank you. Any other question from anybody? There is no other raise hand sign. There is no question in the question box. Jai has just put a question to me that as a clinician, how do you differently treat plasmablastic lymphoma from plasmablastic myeloma? So Jai, it's just same thing that chemotherapy is the main treatment for lymphoma. Of course, plasmablastic lymphoma does not have CD20, so it's not immunochemotherapy. There has been some use of bortezomib with plasmablastic lymphoma, and there are some publications that can be little better than just CHOP. Otherwise, basically, lymphomas are treated with CHOP plus minus bortezomib plus minus upfront autologous transplant, while a myeloma is more of those proteasome inhibitors, IMiDs. So you have bortezomib almost always. You got IMiDs like lenalidomide always this, and upfront transplant is almost always done. So that's the basic difference. I don't think we change the treatment for a plasmablastic myeloma from standard myeloma and a plasmablastic lymphoma. They remain dismal, and we don't have anything great. A lot of things have been tried, but nothing great. So the basic difference of lymphoma versus myeloma treatment: chemotherapy versus targeted therapies and immunotherapy. Okay, so yeah, you got Parimal, one question.
My question is whether, sir, you recommended to do KX in each case is every lymphoma?
Sorry, I think I missed your question.
Say again.
It's not.
Sir, whether you recommended to do KX67 in every cases of classical Hodgkin's lymphoma?
No, I mean, classic Hodgkin lymphoma, I don't do KS67. The first slide which I showed you was purely a research project. Because in a Hodgkin lymphoma, KS67 most often, not only the Rietzlenberg cells will be positive, but a lot of reactive T cells will be positive.
Well, I think that brings us to the end of this fantastic webinar. Before I hand over to Venetia for the official vote of thanks, on my behalf and on behalf of Mumbai Hematology Group, all our Indian colleagues, the huge number of audience from almost 17 countries today. Naresh, thank you very much for sparing your early morning hours. Probably you got up at 4 o'clock, 5 o'clock, got ready for this talk, and you enriched us with a lot of information, and it will help in uplifting the care of patients in this part of the world. So that's from me, and Venetia, over to you for the official word of thanks. Vijay?
Thank you. Thank you very much. I really enjoyed.
Okay, that's it. Right. So, bye-bye. Have a wonderful day. Good night to everybody in India. Okay, bye-bye.
Yeah, so sir, on behalf of Nisha, we thank everyone for their time and this great academic session, especially Dr. Agarwal, Dr. Naresh, and everyone who participated in this academic session. So thank you very much and have a nice time, sir.
Thank you. Thank you so much. Bye-bye, and thank you for helping us in sponsoring this program. Thank you. Bye-bye.